all over the world, from Mexico, Chile, Asia, Africa, and Europe. So I welcome you. I know we are living in different time zones, so maybe in some places it will be morning, some places afternoon. So instead of good evening or good morning, we'll say good day. So today online meeting is about a very important topic, which is updates in Wilm's tumor. We have distinguished guests with us today discussing the most important updates in this important subject. We have our distinguished guest, Dr. George Fuchs, who is the current president of the ESPO, the International Society of Pediatric Surgical Oncology, and is a professor and chief of pediatric surgery, Tübingen, Germany. Welcome, George.
Welcome.
And we have Dr. Shadi Fadel, associate professor of pediatric oncology and director of Borg Al Arab Cancer Center in Alexandria, Egypt, who will talk about the medical side of treatment of oncologic patients with Wilm's tumor. And we have Dr. Ahmed Al-Gendi from Tanta University, who will be talking about the Egyptian experience. So I welcome you all. I welcome my co-host, Professor Mohammed Fahmy from Al-Azhar, who is now in Germany, and for to you all. So we start immediately now with George. Please go ahead.
So, can you see the slides?
Yes.
Okay. Thank you for the introduction, and dear colleagues and dear friends, the invitation to this online meeting for the Egyptian Pediatric Surgery Association is an honor for me. And today I will talk about relevant issues regarding Wilm's tumor, mainly for nephron-sparing surgery and minimal invasive surgery. I will focus also my presentation on some general remarks, the classification of nephron-sparing surgery, especially technical aspects for the surgeons, and my experiences in uni and bilateral tumors, and I will show you, when we have some time, some exceptional challenges. Let me start with some general remarks. These are two well-known persons in the field of nephroblastoma treatment: Max Wilm, a German pathologist and later also surgeon, who published the world-famous monography on mixed tumors on the kidney in 1899. And William Nett, pediatric surgeons from the US who formulated the general principles of nephroblastoma surgery. Worldwide exist different treatment protocols for renal tumors. However, there exist two protocols with relevant differences regarding the time point of tumor resection and risk stratification. The first one is the protocol of the Children's Oncology Group, in earlier times National Wilm's Tumor Study Group. And the second one is the Renal Tumor Study Group, SIOP. The new umbrella protocol for the Renal Tumor Study Group of SIOP implement for the first time clear guidelines for nephron-sparing surgery in unilateral Wilm's tumors and minimal invasive surgery. The new umbrella protocol, based on the experiences of the earlier SIOP trial with more than 10,000 Wilm's tumor patients. This slide summarizes treatment guidelines for the nephroblastoma in the new umbrella protocol of the SIOP group. In my mind, it's essential to know this flow chart to be able to know when you do primary or secondary surgery. And you can see here, the primary surgery is indicated in the age group below 6 months and in children older 16 years. From the surgical point of view and independent from the treatment protocol, we have 5 major challenges in the treatment of nephroblastoma: total nephrectomy versus nephron-sparing surgery in unilateral tumors, nephron-sparing surgery versus minimal invasive surgery, surgery on Wilm's tumor with cava vein thrombosis, surgery of metastasis, and the role of surgery in tumor relapses. Due to the time limit, I will focus my talk on the first 2 points. Allow me to show the pathological basis for nephroblastoma. This is essential to understand the modification of the risk stratification and in the new protocol. Despite the great success in Wilm's tumor therapy, many problems are still unsolved. One of the essential issues within the SIOP group is the relevance of blasphemous subtype in Wilm's tumor after chemotherapy for the prognosis of children. In our historical data of the German group, we found out that the volume of blastema after chemotherapy has an influence on the outcome of children in unilateral as well as in bilateral tumors. The three Kaplan-Meier curves illustrate this aspect and demonstrate a significant differences in event-free survival depending on the amount of blastema tumor components. This is an essential aspect for us as surgeons to perform a complete tumor resection. Now I will switch to the role of minimal invasive surgery in Wilm's tumor. My intention is to show you the advantages and limitations based on the data in the literature and my own experiences. In the literature, the number of all minimal invasive tumor nephrectomies is more than 100 cases. No prospective trials exist. Reason for this phenomenon are different treatment concepts in the National Wilms Tumor Study Group and SIOP. In the National Wilms Tumor Study Group, tumor resection is indicated as an upfront resection followed by chemotherapy. So the surgeons often have to deal with large and fragile tumors with a higher risk of intraoperative tumor spillage. In the renal tumor study group, minimal invasive tumor nephrectomy often competes against open nephron-sparing surgery. Also, small Wilms tumors after chemotherapy are good candidates for MIS on a pure technical basis. The oncological recommendation for this constellation clearly are in favor of nephron-sparing surgery. The SIOP renal tumor study group established a new treatment protocol for Wilms tumor. This protocol also includes for the first time fundamental guidelines for minimal invasive surgery in tumors, as you can see here. First one, resection must be adhere to the oncological principles, including lymph node sampling, small central tumors with a rime of normal renal tissues, tumor removal with back, not with morcellation due to the spillage risk, or through funnel steel incision, and if nephron-sparing surgery is feasible, then it should be preferred. This slide demonstrates the 5 contraindications for MIS and nephroblastoma. On the picture, you can see our own case in which we converted to an open approach. The reason was the impossibility to safely explore the main renal vessels because of the tumor extension behind the ipsilateral border of the spinal column. The basis for these guidelines was a retrospective study about MIS within the SIOP group. We identified 24 patients. This slide illustrates some data. The main aspect was a significant reduction of the tumor volume after chemotherapy. Nearly all tumors had a tumor volume below 300 milliliter at time of MIS. The survival rate was 100%. The intention for this analysis was to establish fundamental guidelines for the new protocol. The main problem in the study was the insufficient lymph node sampling. Lymph nodes were sampled in only 66% of all cases, and in only 2 cases, the sampling was performed according to the guidelines. This is problematic for staging and risk stratification and could lead to a higher rate of relapses. And as you know, if you have a relapse, you have only a 5-year overall survival of 40%. Interestingly, this is not only a challenge in MIS, as well as in open surgery, as you can see here in my own analysis from the GPOH in 2001 series, which include more than 500 nephroblastomas. This slide illustrates a review from PELPS on MIS in pediatric population with a focus on neurogenic and renal tumors. My intention is to show you the problems for the fundamental judgment of the effectiveness of this approach. In more than 50% of all papers, we have no relevant information about negative margins and the lymph node status, which is important, as I mentioned before, for risk grouping and the post-operative treatment concepts. This underlines the necessity of prospective data sampling in the different trials. For an improvement of data management, we developed a new form for MIS and Wilm's tumor, as you can see here. This form will be sent out to the surgeons when they identified on the regular surgical form that minimal invasive surgery was performed. This is important for checking our guidelines and modifying this recommendation after a preliminary period of 2 years when it is necessary. Nephron-sparing surgery is a worldwide accepted surgical maneuver in bilateral Wilm tumors. The indications for NSS in unilateral and central bilateral Wilm nephroblastoma is still subject of a controversial discussion because of the higher risk of tumor recurrence or organ failure. In contrast to the Children's Oncology Group, in the US, nephron-sparing surgery is allowed in unilateral tumors according to the SIOP renal tumor study protocol. However, for better scientific analysis, we need a new classification system for NSS procedures. The first step in the protocol was the establishment of so-called positive criteria for NSS and Wilm tumors, as you can see here. The tumor should be restricted on one pole of the kidney or peripheral at mid-kidney. The volume should be smaller than 300 milliliters. No preoperative tumor rupture, no involvement of the renal pelvis, no vascular thrombosis, and so on. In the second step, we classified the nephron-sparing surgery in our guidelines, and the basis for the classification are 4 aspects, as you can see here. First one is the surgical technique. Nephron-sparing surgery, A, partial nephrectomy, B, enucleation, the surgical resection margin, the pathological resection margin, and the remaining renal parenchyma. This was a point with a lot of discussion because finally, this is a subjective evaluation by the surgeons. And the summary is a formula, as you can see here with an example. And with this formula, we can analyze prospectively all the nephron-sparing surgery procedures in our protocol and have more information about the relapse rate, about the efficiency of surgery, and so on. Let me switch now to technical aspects in NSS. In this part of my talk, I will give you an overview about my personal experiences and concepts. What are the surgical challenges of nephron-sparing surgery? Polar versus central tumor localization, the tumor detection. Detection is sometimes difficult. Infiltration of the renal pelvis. You have to realize an R0 resection. You need not a sufficient amount of remaining renal tissue, single-staged versus staged approach in bilateral tumors, and the management of urinary leakage. This slide highlights the summary on personal recommendations. The first step is the exploration of the kidney and judgment of the tumor extension. Intraoperative contrast ultrasound is necessary. Extended dissection of the renal vessels. I prefer a single-stage approach in bilateral tumors, clamping of vessels, and local hypothermia during the parenchymal phase, selective hemostasis with atraumatic sutures, intraoperative biopsies, and reconstruction of the pelvis and calyces, and when necessary, the drainage of the pilum. This is an intraoperative contrast-enhanced tumor detection with ultrasound. This is a key point for safe tumor resection, especially in tumors with difficult locations. Sometimes it's challenging to identify the border of the tumor from the renal tissue, as you can see here in the schematic illustration. This schema illustrates the management of the central and peripheral renal vessels. In difficult tumors, we perform resection under total vascular exclusion and local hypothermia using ice water. We divide it between an area where the vessels should be stitched and an area where a simple coagulation is possible. This is the peripheral area. And we performed, as I mentioned, all procedures as a single-stage approach. This is an example of an 8-month-old boy. This was a challenging case because of a primary total nephrectomy on the left side in another hospital. You can see the extended dissection of the vessels followed by the reconstruction of the renal pelvis, and the postoperative renal function was normal, and you see here also an MRI postoperatively. This slide demonstrates a safe and blood loss dissection, which is achieved through a vascular isolation of the kidney. Borders between the tumor and healthy tissue can be identified precisely. This is the key step for a marginal R0 resection on the tumor, and we use magnifying glasses in all cases. Another important point is the careful handling of the renal artery. In my view, there is a higher risk of endothelial damage of the vessel wall by using the conventional bulldog clamps. In one of our cases, we had to patch the artery, as you can see here, because of a clamping and an endothelial dissection. We had a similar observation in neuroblastoma surgery, and therefore now we're using the atraumatic Yasagil clamps. And this is a short movie which summarized the step. I hope you can see all these details. The first thing is a wide dissection of all the renal arteries in the hilum, because you can so very well identify the blood supply, then the clamping with the bulldog, then the identify the border. Is really in vascular isolation very easy between the renal healthy tissue and the tumors. You can see here very well the renal pelvis and the pylon. Yes. And then we start with the stitching, the coagulation on the peripheral areas, the stitches in the central areas. In this case, we used a double J stent. It is not necessary in each case. This is fibrin glue and tissue coal. And not in each case we adapted the kidney. In this case it was possible. And you can see here the final result after surgery. Now I will focus my talk on preliminary experiences on nephron-sparing surgery in unilateral tumors. Here you can see an example from a conventional tumor nephrectomy. This picture is more than 20 years old. At that time, we discussed very often the possibility of performing nephron-sparing surgery in selected cases, and the border between the encapsulated tumor and the normal renal tissue is impressive. Dennis Kotze published his own series in PBC in 2013, and his graph shows the difference in the glomerular filtration rate in children with one kidney after tumor nephrectomy in comparison to the healthy population. These observations underline the justification of nephron-sparing surgery in unilateral nephroblastoma. In addition, there is a broad experiences with partial nephrectomy for renal cell carcinoma in adults, demonstrating comparable long-term results as total nephrectomies. Jim Wilde analyzed the historical data from the SIOP study group 2001 patients. The number of the cases in nephron-sparing surgery was 91 in comparison to the total nephrectomy group. In the nephron-sparing surgery group, the tumor volume was lower, as you can see here, at diagnosis as well as after primary chemotherapy. I think this is well demonstrated here. However, 12 from 91 patients had postoperative stage 3. That is not so good. Here you can see how these patients were managed with an intensified treatment concept. In addition, perioperative complication rates were relevantly higher in the nephron-sparing surgery group. From the statistical point of view, there were no differences between two groups. The relapse rate was higher in the total nephrectomy groups. I think this is a result of the patient selection, and here you can see very well how these patients with stage 3 were managed with total nephrectomy, with nephrectomy and radiotherapy. And this is, I think, a really challenging problem. Finally, he could demonstrate there is an equal event-free survival and overall survival of children undergoing nephron-sparing surgery and the unilateral tumors to the total nephrectomy group. And there are also no differences in the subgroup of localized versus metastasized tumors. Now I will switch to the group of bilateral Wilms tumors. Bilateral Wilms tumors are a very specific subgroup of renal tumors. The biological behavior seems to be different than in unilateral tumors. Nevertheless, we need more data of biomarkers for better understanding the biology and the risk stratification. Irrespective of these aspects, we have some challenges from the surgical point of view, especially the development of a metachronous tumor, tumor in the renal hilus, multifocal nephroblastomatosis, tumor thrombus with the major vessels, and unfavorable histology. Let me explain the SIOP recommendation for the management of bilateral tumors. After diagnosis, all children should receive a neoadjuvant chemotherapy. The response should be monitored using ultrasound and MRI. And after a good response, the surgery is allowed after 6 weeks. You can extend the chemotherapy to 12 weeks and then the surgery has to be performed. The question is nephron sparing versus renal transplantation. And you can see that the overall survival rate in the renal transplantation group is really poor. This is a selection of some data from the literature, and especially interesting since it's data from Hamilton. You can see here a huge gap in the 5 overall survival. The reason is these are the anaplastic tumors and these are the tumors with favorable histology. I mentioned the constellation of non-responders after diagnosis of the bilateral Wilms tumors. This is a 1.5-year-old girl where we didn't observe any response after 4 weeks of chemo. We performed the two-cut biopsy and the pathologist described a stromal predominant tumor. And under these circumstances, we decided to perform a tumor resection as a single-stage approach. After surgery, the renal function of this child was normal. And you can see here only the management of the right side with this huge tumor with a longitudinal nephrectomy, and the remnant was 50 to 60%. This is another interesting case where we had a tumor thrombus in a bilateral constellation, as you can see here. And we discussed this case very long with our study board, and due to the calcification, we performed a nephron-sparing surgery on both sides and removed the thrombus. And this child is without any evidence of disease. The tumor extension in the renal hilus is a major technical problem for most of the surgeons. This constellation is a clear indication for nephrectomy or renal transplantation, and we developed a surgical technique for nephron sparing and surgical and central localized tumors. This is an example of a 2.9-year-old girl, longitudinal partial nephrectomy, and you can see here the right side. The management of the right side with an excellent urological follow-up, and the postoperative, you can see we have a good renal function on both sides. Our own series, we have 41 cases with bilaterals, and this include 14 cases with longitudinal partial nephrectomy. You can see here the follow-up is adequate with 56 months. And these are the additional major procedures. We performed in one case a hemiapatectomy, another case a diaphragmatic resection. You can see the clamping time of the kidneys is 20 minutes and the operating time more than 200 minutes. And we had complications, that's clear, especially urinary leakage, which were managed with redo procedures or CT-guided drainage. And the outcome was excellent. We had 3 relapses and 1 death with a metastatic disease and an anaplastic constellation. So now, due to the time limit, I think we should discuss some relevant issue. I will skip this slide about exceptional challenges. It's a very interesting part because this includes the management of nephroblastomatosis, transformation of nephroblastoma to an anaplastic Wilms tumor, the management of horseshoe kidneys, and redo nephron-sparing surgery. After nephron-sparing surgery, we can discuss this, and I will summarize all these things. First, nephron-sparing surgery is indicated in selected unilateral Wilms tumors. Longitudinal partial nephrectomy can avoid a tumor nephrectomy in central Wilms tumors. The single-stage approach in bilateral Wilms tumors is safe. There is a high relevance of intraoperative biopsies. We have a good functional long-term outcome. What I could not show because of the time limit, redo surgery after nephron-sparing surgery makes sense with an analog oncological outcome. And in conclusion, nephron-sparing surgery has a defined importance in the treatment of uni and bilateral nephroblastomas. It is justified provided that procedures are executed by experienced surgeons with a center of excellence. Without any doubt, the treatment success in children suffering from cancers is a result of a multimodal treatment approach in which surgeons play a key role as one mosaic stone. Thank you for your attention.
Thank you so much, Dr. Fox, for a very interesting and impressive presentation on the updates and a huge experience in Wilms tumor. And you make us actually regret putting some time limits on your presentation because there are actually very interesting points. Probably if time will allow, we can come back and discuss some of these very interesting points. As you all know, Wilms tumor and oncology in general is a multidisciplinary treatment. It's only not a one-man show for the surgeon, but we need always the oncologist to sometimes before surgery, sometimes after surgery. And we have an expert coming from Alexandria, Egypt, dealing with these cases, who is Dr. Shadi Fadel, the General Director of Burj Al Arab Cancer Hospital. Welcome, Shadi, and go ahead for your presentation.
Welcome, everybody. Thank you for giving me the opportunity to present this data. I will go today through the umbrella protocol because this the protocol that we follow in most centers in Egypt. And just a word to say about the umbrella protocol, it is not a trial, it is or at the guidelines for the treating physician for Wilms tumor in children. As you all know, Wilms tumor, renal tumors in children is common, and the most common is Wilms tumor. Only 11% of tumors that arise in the kidney of children are non-Wilms tumors. Though these tumors are rare, the non-Wilms tumor, although they are still incorporated under the umbrella protocol, and that's why they call it the umbrella, because it covers all the tumor arising from the kidneys, and as well it includes guidelines for adults that develop Wilms tumor. The hallmark of the SIOP protocols that they give pre-operative chemotherapy with the two main drugs, the vincristine and the actinomycin, since the early 1970s. And this does not need to do a biopsy before doing this. The aim of this treatment is to downstage the tumor so that we will decrease the post-operative treatment to avoid, of course, the doxorubicin and radiotherapy. And these two drugs are known for their long-term side effects, because we have very good survival now for children with Wilms tumor, as you will see later. So we are careful about the long-term side effects. When we decrease the size of the stage of the tumor, about 20% of patients will be spared the effect of the doxorubicin and radiotherapy. However, this approach is associated with the risk of misdiagnosis, which is about 5% to treat children with non-Wilms tumor through a Wilms protocol. You can see from the immediate nephrectomy versus pre-operative chemotherapy trial that has been done by the UK group, Kathy Pritchard and her colleagues, that the outcome is likely similar, and the outcome from the COG trials and the SIOP trial is similar. There is no difference in the overall survival if you start with a surgery, if you start with a chemotherapy. However, if you see in the same trial, patient with stage 3 on those who received an upfront nephrectomy or those who received a delayed nephrectomy, you could see that only 10% of patients who received a delayed nephrectomy after chemotherapy are stage 3, while about 30% of patients who received an immediate nephrectomy were stage 3. So these are the 20% that the upfront chemotherapy have given an advantage to avoid giving the doxorubicin and the radiotherapy in the post-operative period. And this is the well-known SIOP, previous SIOP trial, the SIOP 2001 trial, and the aim of this trial was to exclude giving the doxorubicin in patients with stage 2 and stage 3 in the post-operative period. And it has shown nicely that there is no difference in the overall survival and the event-free survival, 2-year and the 5-year overall and the event-free survival between patients who received doxorubicin or not. You could see that 2-year event-free survival at the level of 92% and 88% for those who received and who did not receive the doxorubicin. However, we'll come back again to this later to decide which patient will receive doxorubicin or not, if they are stage 2 or stage 3. So what the umbrella protocol dictates us to do as a diagnostic workup: when we see a child, we'll go through the history, the clinical status. Age is very important because it determines if we will do the biopsy or not. The lab, the abdominal ultrasound, abdominal MRI is preferred. However, if you do not have at your center a readily available MRI, you could go with a CT. If you still have no diagnosis, you could do an MIBG to exclude the neuroblastoma and an optional core biopsy, of course. For the history taking, it is very important when you take history and do a clinical examination for a child with a suspected Wilm's tumor, is to look at the presence of a syndrome like the Weger and the Dennis-Drash, because the presence of these syndrome malformations will affect the decision for the treatment. And a good proportion, it's not very large, but a good proportion of your patient will be having these syndromes. And again, please stress for your residents and fellows that when they see a patient with a Wilm's tumor, they should not forget to do a blood pressure testing, because a quarter of these patients are having hypertension. And if this child is admitted to the hospital to receive the pre-operative chemotherapy and hypertension is overlooked, it could be having a disastrous outcome. The malformations that are associated with the Wilm's tumor could be a genitourinary malformation, aniridia, 1%. Interestingly, 1/3 of patients with aniridia will have Wilm's tumor. Hemihypertrophy, try to measure both limbs on both sides. Malformation of the ears. And there are 3 syndromes: the Weger, the Dennis-Drash, and the Overgross syndrome. And these syndromes are associated with renal dysfunction. So sparing the nephron-sparing surgery will be of much important issue in these groups, and it should be discussed upfront in these patients having the Weger and the Dennis-Drash. So it's our job to pick up these patients who are having these constitutional predisposition syndromes. If you go to the laboratory workup, this is the routine that we do for every patient. Coagulation parameters is important because about 5% of patients will having Wilm deficiency, and this will cause massive bleeding for the child. So we should ask for Wilm factor. Urinary catecholamines to differentiate from the neuroblastoma. What we do at the radiological workup, the ultrasound abdomen, is a routine for any child with a mass. MRI, as we have told you, it is important to avoid ionizing radiation. However, if you don't have it, you will go with a CT with contrast. And MRI is important again for the differential diagnosis of the multiple Wilm's tumor from nephroplastomatosis. So if you have multiple tumors in both kidneys, the diffusion weighted images and the perfusion studies could tell you if this is a nephroblastoma or a nephroplastomatosis. CT chest, non-contrast CT chest became mandatory because since the late Newitz 3 study, CT chest was not used to stage our patient. However, under the umbrella protocol, CT chest is mandatory. And you could see from this study, from the Newitz study number 4 and Newitz 5, that the CT positive metastases that could not be detected by chest X-ray is very high, and it is associated with the primary stage of the tumor. The higher the stage of the tumor, the more nodes, the more metastases you could see on the CT that doesn't be seen on the chest X-ray. So these data should not disregard us from using the CT chest, and we should do it. However, does this affect the survival or not? In this paper from the COG group, it doesn't affect the survival if the child receives 3 drugs, the vincristine, the actinomycin, and the doxorubicin. But if the child receives only 2 drugs, chemotherapy, the vincristine, and the actinomycin, patients with CT-only metastases were having an inferior survival. And in the SIOP protocols, we use neoadjuvant vincristine actinomycin only without the doxorubicin, unless in certain situations. So this piece of information is important for physician using the SIOP protocol, that we should rely on the CT and not the chest X-ray for detection of the lung metastases. However, if we look to the SIOP 2001 study for patients who received treatment regardless of the CT nodes and only regarding the chest X-ray, you'll see there is no effect on the outcome and the overall survival because patients with metastatic disease in the SIOP protocol received 6 weeks of 3 drugs, and who doesn't have metastases receive 4 weeks of 2 drugs only. So this again confirmed that if we add doxorubicin for lung-only metastases patients, CT-only metastases patient, it will overcome the effect. But if you are using 2 drugs, it will not overcome the effect. And for the pulmonary lesion, to describe it as metastasis, not every lesion could be described as a metastasis. If it is calcified, it is not a metastasis. If it's a ground glass, especially in these days with the presence of the COVID-19, it is usually not a metastasis. If it's linear, triangular, it is not a metastasis. A metastasis is rounded, sharp edges, and peripheral. So you need to sit with your radiologist to distinguish between lung deposit and no lung deposit. In the SIOP protocols, we do not depend on the biopsy. We use the radiology for the diagnosis. However, in some instances, we should go for the core needle biopsy. If the child age is more than 6 years, we should do a core needle biopsy before we embark on the neoadjuvant chemotherapy, because the risk of having a renal cell carcinoma rather than a Wilm's tumor is high. If you have a UTI, a psoas infiltration, which is very rare with the Wilm's tumor and more common with the neuroblastoma. If you have a pulmonary metastasis in a child younger than 2 years of age, it's probably a rhabdoid tumor, not the classic Wilm's tumor. If you have extrahepatic and extrapulmonary metastasis, for example, brain or bone metastasis, it's likely a non-Wilm's tumor like the clear cell sarcoma of the kidneys. And if you have an unusual finding by the imaging, by your pediatric radiologist who will ask you to do the core biopsy, if you have hypercalcemia or an elevated LDH as well, these are indications to do a core biopsy before we are going to embark on the neoadjuvant. But we should know that cutting needle biopsy will not differentiate Wilm's tumor from nephroblastoma. It will not differentiate from diffuse anaplasia and focal anaplasia, of course, because diffuse focal anaplasia could come into the path of the needle biopsy. It will not differentiate the stromal subtype of the Wilm's from the embryonal rhabdomyosarcoma if you are interested in this differential diagnosis. Cystic tumors are not to be biopsied because it will rupture. And of course, children younger than 7 months, 6 months of age, they will go on upfront surgery and they do not need to do a biopsy or a chemotherapy before doing this. So if we move to the treatment guidelines, the general guidelines, the pre-operative chemotherapy for all the patients, children younger than 6 months or older than 16 years should go for upfront surgery. Children between the age of 6 and 16 should have a core biopsy before the chemotherapy. The SIOP is to give chemotherapy to downstage, so the post-operative treatment intensity will be decreased. And as well, the plasma Wilm's tumor is very important if you give neoadjuvant chemotherapy. In the COG protocols where surgery is upfront, the presence of plasma predominant is not prognostic. While if you give neoadjuvant chemotherapy and the plasma cells didn't respond well and they are predominant, and I mean by predominant, it constitutes about 66% or more of the tumor, then this is a prognostic factor. So if you do an upfront surgery for patients that will be plasma predominant after neoadjuvant chemotherapy, you will lose this information. So these are the double-fold information that we get from the neoadjuvant chemotherapy, the downstaging and the plasma predominant. For those younger than 7 months, we do not do any neoadjuvant chemotherapy because at the first month of age, it's the congenital mesoplastic nephroma the most common. After that, still Wilm's is the most common, but other tumors are common as well. Why we do not give chemotherapy for these children? Because mostly their weight will be very low and their ability to withstand the toxicity of the vincristine and the actinomycin will be higher. And the percentage of patients developing side effect from this chemotherapy at this age is higher. And the third cause that most of these patients, if they develop Wilm's tumor and be treated by surgery, they will be in stage 1, stage 2 Wilm's tumor. So the need for post-operative chemotherapy will not be extensive, which is the goal of the SIOP protocols. This is how we do it. If we have a child below the weight of 12 kilograms or 5 kilograms, we reduce the doses by 33% and even by 50% for children less than 5 kilograms. And in this age group, less than 6 months of age, we will try to avoid radiation at any cost, and only will give radiation for those with diffuse anaplasia or local stage disease 3 that is advised to discuss it with your local coordinator of your radiotherapy, because omission of radiation in this situation is difficult, and giving radiation in this situation as well is difficult. What chemotherapy we do? The 2 drugs, the actinomycin and vincristine, very tolerable without major side effects in most of the children. This is the same slide of the umbrella protocol. We give the chemotherapy 4 weeks if we having stage 1, 2, 3 by the CT or the MRI, and we give 6 weeks 3 drugs if we have stage 4 metastatic disease, and for stage 5 the bilateral disease, we give the actinomycin vincristine alternating with the carboplatin, but we give it now at 6 weeks, not 4 weeks for the bilateral disease. Just a word for the pathologist, when you receive a kidney removed after neoadjuvant chemotherapy, they need to label it like this, because if they want to know if there is a focal or diffuse anaplasia, you have to do many slides from different parts of the kidney and from different parts of the tumor to label it as a focal or a diffuse anaplasia. What we need to see from the pathologist is the type. It's regressive, mixed epithelial or stroma or plastima, and this depends on the percentage of the cells present in the specimen. To differentiate between focal and diffuse anaplasia, because this will differentiate very much in the post-operative treatment. And mixing all this, we will classify patient pathologically as low risk, intermediate risk, and high risk. So what we receive from the post-operative pathology report, that we have a Wilm's tumor with a stage 1, 2, 3 locally, and a risk of low, intermediate, or high risk. And accordingly, we will give the chemotherapy. What we have discovered from the SIOP 2001 protocol, that the volume of the post-chemotherapy tumor is important in the recurrence. We have stated that doxorubicin is not indicated for patients with stage 2, stage 3 Wilms tumor in the SIOP protocol. However, if this patient having a volume after the 4 weeks of neoadjuvant chemotherapy of more than 500 cc's, their outcome will be less than other patients unless they receive doxorubicin. So in the umbrella protocol, this is the only indication to give doxorubicin other than anaplasia for patients with stage 2 and stage 3. If they have a post-chemotherapy after the 4 weeks and before the surgery, a tumor volume of 500 cc's. If we, according to the stage and the risk group, we will give the post-operative treatment, mostly of actinomycin and vincristine. That's the AV. We only give the doxorubicin, the AVD, for patients with high risk and patients with stage 3 intermediate risk, more than 500 cc's pre-operatively. And radiotherapy is only preserved for patients with stage 3 or stage 2 diffuse anaplasia. And this will constitute about 10% of our patients, and 90% of our patients, according to this protocol, will be spared the deleterious effect of the doxorubicin and radiation. These are examples of the regimen according to the stage and the risk. The higher the stage, the higher the risk, the more the chemotherapy that we give. And this is important for the multidisciplinary team. According to this protocol, the timing between the last chemotherapy we give as a neoadjuvant and the start of the chemotherapy as an adjuvant is at max 21 days. That's to say, after the last chemotherapy we give, we'll do the CT, we will send the patient for surgery, recovery from the surgery, receiving the pathology report, doing the post-operative evaluation, all of this in 3 weeks, because more delay of chemotherapy than 21 days between the last chemotherapy, not from the surgery. We measure it from the last chemotherapy neoadjuvantly. We should wait at least, at max 3 weeks. This was for the local Wilms tumor. For metastatic Wilms tumor, there are general guidelines that we do biopsy of lesions that are not radiologically convincing as a metastasis, or lesions have to be assessed before the nephrectomy. If there is discrepancy between the histology of the metastasis and the primary, we will go to the highest risk histology. If we are going to give flank irradiation and pulmonary irradiation, we could delay to give it concomitantly rather than separately to avoid overlap in the lesions. For metastatic disease, we will not give 4 weeks, we will give 6 weeks, and we'll add the doxorubicin. Then the patient, even metastatic with no complete response, will go for surgery as well. What is important is the pre-operative chemotherapy is the lung nodules. If the lung nodules is less than 2 millimeters, we do not consider it as metastasis. Between 3 and 5 millimeters, we consider it as metastasis. More than 5 millimeters, we consider it as metastases. Patient with metastasis, any other sites than pulmonary, we will consider it as metastases and we'll give the 6 week with the doxorubicin. I will skip this slide because it's detailed about the type of the chemotherapy we give and according to the response. According to the response to the chemotherapy, we evaluate at week 10, and then we decide to give more or less chemotherapy for the metastatic patient. For the bilateral patient, these guidelines will be applied for bilateral Wilms tumor, bilateral nephroblastoma, a unilateral Wilms tumor with a nephroblastoma on the other side, or a Wilms tumor in a single or a horseshoe kidney. These patients will not undergo upfront surgery, of course, either in the COG or on the SIOP protocols. And the outcome was less than patient with unilateral tumor, and it is getting better in different SIOP protocols, and it's reaching about 70% overall survival. In the SIOP protocols, you could see that patient with stage 5 having the least outcome. Stage 5 is the bilateral tumor compared to stage 1, 2, 3, and 4. And in patient with bilateral tumor, the most important prognostic factor is still the local stage of each tumor. And patient with either stage 3 on either side will have an outcome less than patient with stage 1 or stage 2 on both sides. That's important for patients with the Dennis Drash or the Weger syndrome. The percentage of end-stage renal failure in patients with Wilm's tumor, bilateral Wilm's tumor, is much higher than in patients with unilateral Wilm's tumor, of course. And again, for patients with the Dennis Drash or the Weger or the genitourinary malformation, the incidence of end-stage renal failure is very high. So the aim in the treatment of bilateral Wilm's tumor is to give upfront chemotherapy, decrease the size of the tumor as much as possible, do bilateral nephron-sparing surgery in both sides if we are able to do, and if not, we'll go for nephrectomy at least on one side and then adjuvant chemotherapy after the surgery.
2
MRI,
minutes, Dr. Shadi. 2 minutes.
Yes. The MRI is very important for this patient to differentiate nephroblastoma from multiple bilateral Wilm's tumor, because for the nephroblastoma we will not need to do any surgery for these tumors. How we do it? We give 6 weeks of vincristine actinomycin, do an assessment. If we could spare one kidney, we will go for surgery. If not, we will go for another 6 weeks. Both the German and the French group have shown that more than 3 months, more than 12 weeks of chemotherapy neoadjuvantly will affect the outcome in the bilateral Wilm's tumor. So we stop at 12 weeks if even there is a response, and we'll ask the surgeon to go in and remove the tumor. Just one slide for the radiation. These are the changes that we have done between the SIOP 2001 and the umbrella protocol, that we omitted a boost for the para-aortic lymph nodes if they are negative, and those to the contralateral kidney should not increase than 12 grays to avoid renal failure. These are the indication of radiation if you have a high risk stage 2 or stage 3, and intermediate risk with positive nodes or a rupture of the tumor. Timing of the radiotherapy is more flexible in the umbrella protocol. We could wait till 2 or 4 weeks rather than the 10 to 14 days that are used in the COG protocols. The SIOP protocols are using a higher radiation doses compared to the COG protocol, but less number of patients who receive these radiation. These are the most important changes. No boost for the stage 3 negative lymph node removed or positive node removed, and the whole lung irradiation dose have came down to the 12 gray. This diagram will show the pathway of your patient, which histology, which stage, and which treatment you will give to your patient. I will skip patient for relapsed Wilm's tumor, but only they are classified into 3 groups: standard if they receive 2 drugs only, high risk group if they receive doxorubicin, and very high risk group if they received anaplastic histology or plasma type treatment in their first Wilm's tumor. These are the chemotherapy that we give for the for the relapsed Wilm's tumor, and there are now some data that high-dose chemotherapy with autologous bone marrow transplant with single drug melphalan only is having survival advantages in patients with relapsed Wilm's tumor. These are the follow-up of the patient after the end of therapy. We follow up after every 3 months for the first 2 years, every 4 months in the 3rd year, every 6 months later, and after 5 years, we follow up yearly. What is important is to measure the blood pressure and test for albuminuria every time the patient will come to see us. And for the second time, I will stop here, and thank you very much.
Thank you very much, Shadi, for this extensive coverage of the other face of the coin in treating Wilm's tumor. As you all know, Wilm's tumor originally have a good prognosis, but all the efforts are now with international trials to improve and fine-tune treatment, chemotherapy, radiotherapy, and surgery to achieve even better and higher survival. Dr. Fahmi, you would like to introduce the next speaker? Dr. Abdelbari.
Yeah, I think it's much better to be introduced, but by one of the Tanta team.
Well, I know him very well. I know all Tanta team. They are my friends. But Ahmed Al-Gandhi actually is a very active researcher from Tanta. He's dedicated truly, and he participated in a lot of interesting studies recently that has been published in international congress or journals, with a team, a very nice team from Tanta, not only from Tanta, but from Cancer Hospital and from other, some of them are multi-center trials. So it's nice to see what is the situation in Egypt about Wilm's tumor and see what Ahmed Al-Gandhi will tell us. Ahmed, please go ahead.
Thank you very much, Professor Samah. Thank you, Professor Fahmi. Good evening. Thanks for the invitation from Professor Sharif Shahata and the Executive Board of EPSA and all cohort. I also would like to welcome Professor Fuchs and Professor Hall. We have nothing to disclose. Wilm's tumor is a surgical neoplasm, per surgeon's view. Its management is a true story of success regarding multimodal therapy in oncology. Recent reports indicate that 90% of the patients could have an opportunity to be cured. Surgery plays a pivotal role in the management, and evidence-based guidelines for resection have been established by COG, SIOP, German Association of Pediatric Oncology and Hematology, and the United Kingdom Children's Cancer and Leukemia Group. Regarding operative guidelines, a generous transabdominal transperitoneal or thoracoabdominal incision is preferred for adequate exposure. However, midline or paramedian incisions should be avoided. Complete exploration of the abdomen followed by localization of the tumor from lateral to medial, and then exposure of both the tumor and the renal hilum. Ligate the vessels and the ureter. Ureter should be divided as distally as possible. Eventually, complete tumor resection is the target of the procedure. Lymph node sampling is an integral part of the surgical operation, and it is essential for a precise staging of the patient. However, what is the optimum number of samples? COG recommended 7 nodes, and SIOP declared 6. Formerly reported that only 3 nodes were sufficient. What about the Egyptian practice? A recently published study showed that the majority of Egyptian surgeons and centers follow COG protocol. Regarding timing of surgery, COG recommends upfront section for all patients with unilateral Wilm's tumor. However, indications for a biopsy and pre-operative chemotherapy as follows. Massive, initially unresectable tumors, thrombus above the hepatic veins, obvious tumor spill or lymph nodes involvement, extensive metastatic disease, equivocal pre-operative imaging, pituitary or horseshoe kidney, and unilateral tumor predisposed to metachronous disease. Surgical violations as per COG protocol, unwarranted preoperative biopsy, incorrect surgical incisions, intraoperative tumor rupture and spillage, absence of adequate lymph node sampling less than 7 nodes, and extensive resection of vital organs other than adrenal gland or small part of the diaphragm. This study aimed to evaluate short-term outcomes of the patients with unilateral Wilm's tumor. Other purpose to analyze surgical aspects performed during nephrectomies, types and numbers of iatrogenic protocol violations, and their impact on the overall prognosis. This is a retrospective analysis including all children with unilateral Wilm's tumor who were treated within 3 tertiary Egyptian centers between 2016 and 2019. Data collected included general demographics and characteristics of the patients, imaging, treatment regimens, full surgical details, post-operative pathological reports, complications, and survival outcome. Management protocol in all participating centers was uniform and conducted accordingly to COG guidelines, with upfront radical nephrectomy with lymph node sampling as the initial procedure. This is a patient with a left-sided Wilm's tumor not crossing the midline in the evaluation of the initial CT. Laparotomy was performed and complete exploration was achieved. Complete tumor resection and bloodless operative field were achieved as aforementioned. Another case of left-sided Wilm's tumor. Laparotomy and dissection and exposure of the tumor by opening the retroperitoneal space. Complete tumor resection and lymph node sampling. A female child with right-sided Wilm's tumor appears in both abdominal ultrasound and abdominal pelvic CT. Upfront radical nephrectomy with lymph node sampling were achieved with bloodless operative field. Also, patients were closely monitored by abdominal ultrasound and chest X-ray and abdominal pelvic computed tomography in addition to chest CT also. Follow-up visits were scheduled at outpatient clinics according to hospital's internal guidelines. Overall survival and event-free survival rates were estimated by Kaplan-Meier method and reported at 30 months. Surgical violations were statistically analyzed by logistic regression. 37 patients were included for analysis with a median age of 3 years. This table shows the patients' general demographics. 20 patients were presented by abdominal mass as the main mode of presentation. 4 patients were presented with associated pulmonary metastasis at the time of diagnosis. 5% of the patients were under 3 years of age. This table shows clinical characteristics and staging of the patients. 5 patients had associated non-syndromic congenital anomalies. And staging according to the current COG guidelines, there were 12, 11, 10, 4, stage 1, 2, 3, and 4 patients. 4 patients were of unfavorable histopathological reports, the post-operative. This graph shows the plan of management conducted in the current study. 30 patients underwent a primary surgery, whilst the remaining 7 had a delayed resection. 4 of them were metastatic, and the other 3 were of stage 3. 5 patients had delayed resection due to an equivocal preoperative imaging with adrenal neuroblastoma due to upper polar lesions of the kidney, and the other 2 had unwarranted biopsy. This table shows surgical aspects during Wilm's tumor resection. All patients included in this study had upfront nephrectomy or delayed resection through transverse transperitoneal incision. 19 patients had adrenectomy as a part of en-bloc resection during tumor nephrectomies. Other two patients had additional resection of a small part of the diaphragm due to tumor adherence. 8 patients had no lymph node samples at all retrieved within the specimens. Intraoperative tumor rupture and spillage occurred in 5 patients during primary surgery. This table shows post-operative events, therapies, and survival data. There was no operative mortality in the series. 3 patients presented with adhesive intestinal obstruction in the post-operative period that managed surgically. At the end of the study, 35 patients were still alive. Regarding survival data, 30-month overall survival and event-free survival were 85% and 82% respectively. 6 patients had relapsed at a median follow-up time of 22 months, 4 local and 2 distant with pulmonary metastasis and recurrences. All locally relapsed patients had tumor rupture and spillage during the primary surgery. Disease progression occurred in 3 children, 2 with lung recurrence and 1 with local relapse, and they died without any surgical intervention. This graph shows 30 months overall survival of 5%. This graph shows event-free survival is 82%. 27 surgical violations were occurred among 25 patients, as 2 patients had a double violation. This table shows the types and numbers of practiced surgical violations in this study. Failure of lymph node documentation, either no sampling at all of lymph nodes or suboptimal sampling less than 7 nodes, represented 74% patients encountered. Intraoperative tumor rupture accounted for 5 cases, and 2 cases had unwarranted preoperative tumor biopsy. Regarding the influence of surgical violations on the outcome, they were not correlated with mortality. However, they had a significant impact on tumor relapse. On further analysis, intraoperative tumor rupture was found as the only significant predictor for recurrence among all violations encountered. This table shows the logistic regression of the surgical violations and their impact on the relapse. This graph demonstrates the occurrence of violations in relation to tumor stage. You can see the distribution of violations among stages of patients. The current study has few limitations, such as retrospective design, small sample size, few number of participating centers with short-term results. So we are conducting another study with more numbers of patients with longer follow-up period. In conclusion, favorable outcomes could be achieved by compliance with evidence-based guidelines. Surgical violations were correlated with relapse. However, in multivariate analysis, only tumor rupture and spillage was of statistical significance. Failure of lymph node documentation, either absence or suboptimal sampling, was the main problem encountered among all violations, and this should be avoidable in the future practice. Eventually, we propose that careful assessment of tumor resectability and adequate lymph node sampling can surely reduce the violations in the future. The study has been presented at EPSA Belgrade, published in Egyptian Pediatric Association Gazette. Thank you.
Thank you very much, Ahmed, for presenting this important study about the violations in Wilm's tumor. And now it is time for all the speakers to have received some interesting questions from the chat area. The questions and discussion will be moderated by our panelists. The first one will be Professor Akram Al-Batarni, and he will choose questions for Dr. Fuchs. Akram, please go ahead.
Okay, Dr. Professor Fuchs. The first question is, can you explain more about nephron sparing surgery in a unilateral Wilm's tumor?
What will you know about this procedure, the indications or?
Yeah, the indications, yeah, and to explain more what you explained as longitudinal nephrectomy.
Yeah. The longitudinal partial nephrectomy is a special technique which was developed from my side. And it is the indication for the longitudinal partial nephrectomy is mainly in central localized Wilm's tumors. And this is not, so it makes not sense to perform a longitudinal partial nephrectomy in unilateral tumors because according to the guidelines from SIOP, central localized tumors in unilateral constellations are indications for nephrectomies, but in bilateral tumors, everything is allowed. And in this constellation, you can resect the half of the kidney, and you have the possibility, when you perform a longitudinal resection, of a very good exploration of the central area, including the vessels. And in this constellation, we performed also a lot of vessel reconstruction in the renal hilum. This is sometimes necessary for the blood supply, but it works. And finally, you have 50% remnant from the kidney and a good renal function.
Okay. From Dr. Sharif Shahata, are you using tissue sealers like Tachyseal in different sparing surgery?
Yes, we use Tahoseal, we use fibrin glue, yes, and then we take Tahoseal. And this is important. The first thing is if you have an injury of the renal pelvis, we put a needle in the renal pelvis and stitched all the injuries. And then we check the tightness with 5 or 10 milliliters fluid. And additionally, we put fibrin glue on the surface and Tahoseal. And it works very well.
Another question is Wilm's tumor genes 1 and 2, do they have implication in the decision for management after tissue diagnosis?
No.
No. What is the renal function at 2 to 3 years post bilateral nephron sparing surgery?
If you see the data analysis from the SIOP and from the National Wilm's tumor study, then we have in 10 to 12% a renal insufficiency in all the series. I think Sabine Irtan published the data together with Professor Bergeron from Paris about the SIOP, and it is the same result like in the National Wilm's tumor study with 10 to 12% renal insufficiency. However, in centers of excellence with more experiences in nephron-sparing surgery in bilateral tumors, the rate is lower, significantly lower. Yes.
If tumor spillage occurs intraoperatively, what's next?
There is a clear consequence. If you can distinguish between a minor spillage and a major spillage, yes. When we perform an open nephrectomy or an open partial nephrectomy, then we put a towel behind the kidney and then we start with a resection. And if you have a minor spillage, then it could not have a consequence. But if you have a major spillage, then you have to remove what is possible, and all the children receive a postoperative irradiation. This is an obligation. Yes.
What are the measures you use to define the limits of the tumor during a nephron sparing surgery?
Sometimes it's very difficult to identify the tumor because the normal renal tissue is over the tumor and you could see the tumor. And one of the best options to find the borders between the tumor and the healthy tissue is the contrast-enhanced ultrasound. I show you a short movie in my presentation, and we perform this directly on the kidney in the OR. And so we market the border sometimes with needles. Yes, you can see the needle, the apex of the needle in the ultrasound, and then you have a safe resection. And the next step is, if you have performed a marginal R0 resection, we take from 3 different areas, frozen biopsies, And if the pathologist said, hey, okay, you are in healthy tissue, you have healthy margins, then it's okay. Otherwise, we perform a resection.
So it's ultrasound and a fresh frozen biopsy.
Yes.
The other questions, I think, are for Dr. Shadi and Dr. Ahmed Al-Gindi. And thanks, Dr. Fox. We will return to you with direct questions from the audience. Please, my colleagues, other moderators,
Dr. Debeki. Yeah, Debeki already. Yeah.
Dr. Debeki here?
If not, you can carry on, Dr. Abdulaziz.
Okay. Good evening, everyone. I have a question to Dr. Ahmed Al-Gindi. How can we weight the tumor to know is it more or less than 500 cc? Dr. Ahmed?
Please, I didn't hear you, Dr. Muhammad, please.
Okay, how can we weight the tumor to know is it more or less than 500 cc?
Yes.
You mean intraoperative measure?
No, I think the question's pre-operative. Yes, pre-operative by ultrasound measurements. And after resection, it will be weight for the millimeters, how many milligrams. Okay, this is,
okay.
I know this question because the tumor is less than 500 milligrams. It will be sometime in the subgroup of very low risk in the COG protocol. And such patients can be underwent just surgery without any further therapies. Okay, if the tumor less than 500 milligrams in the weight and the patient is unilateral non-metastatic, you can go just with a surgery without any further chemotherapy or radiotherapy post-surgical resection. Okay, so surgery alone is sufficient in such a group.
Okay, thank you, Dr. Ahmed. Another question: is there a relation between the age and the occurrence of the violation?
No relation. The surgical violation is just surgical practice and avoid tumor upstaging by unwarranted biopsy or intraoperative spillage and the tumor rupture. No relation between age and violations.
And your retrospective study is only on the open surgery, not on the MIS?
Yes. No. Conventional surgery for all patients.
If you have extensive mass in unilateral case, do you prefer to do just a resection of the mass or nephrectomy?
No, nephrectomy. Total radical nephrectomy. Total radical nephrectomy.
You don't go to the NSS. You don't prefer NSS.
No, we do. We don't do in Egypt nephron-sparing surgery for unilateral tumors. However, we reserve the nephron-sparing surgeries for the bilateral tumors.
Okay, thank you, Dr. Ahmed.
Thank you.
Thank you. Dr. Sameh?
Yes.
We have no more questions from the chat room.
You can take questions for Dr. Shadi, Dr. Mohammed Abdulaziz. Can questions for Dr. Shadi instead of debate?
I don't have more questions.
Well, I think there are some questions unanswered for Dr. Fox. Shadi, of course, Shadi, of course, you know the majority here are surgeons, so most of the questions will be surgically oriented. But I'm sure you are enjoying the discussion. Yes, please go ahead.
I have questions here for Dr. Shadi.
Good.
When upfront chemotherapy is not advisable, I think he mentioned this, but please reassure the question.
We will not give chemotherapy for children younger than 6 months of age. We will give chemotherapy for children with age of more than 16 years. And for those between the age of 6 and 16, we'll go for biopsy before decision for upfront chemotherapy. And if we have any doubt that it is not a Wilm's tumor from the radiology, from the hypercalcemia, from the site of the metastasis, we'll do the biopsy before the Wilm's tumor. So if you are sure that it is a Wilm's tumor either by biopsy or the radiology, we'll give chemotherapy for every patient, unless younger than 6 and older than 16.
Yes.
Another question, Akram, another question.
At what stage is the decision made to include doxorubicin in patients with stage 2 and 3 since one has to wait 4 courses before assessing the 500 cc volume, is it given preoperatively? And also there's a question on how to assess the volume.
Okay, when we will add the doxorubicin, we will add it after the surgery in the adjuvant, because we give 4 weeks without doxorubicin, do a CT, and in the CT we will know the volume. The cc's centimeter is the volume. So we will know the volume after the chemotherapy, do the surgery, and after the surgery, we will get the images of the preoperative CT, find the volume, and associate it if to give doxorubicin to stage 2 and 3 or not. How we will measure the volume, it is not a weight, it's a volume. So we do not have to have a weighting machine intraoperative. It is a volume that we could get the information from the CT, height, width, and thickness. We multiply it and we get the thickness. What is different and what is confusing here is the COG protocol. If you have a 500 grams tumor, stage 1, we will not give chemotherapy. This is grams and not cc's. So if you are going into the SIOP protocol, it's important about the volume. If you are going into the COG protocol, it is important about the weight. So for this stage 1, less than 500 grams, that you have to wait intraoperatively, we will not give chemotherapy.
So can we differentiate between nephroblastoma and Wilm tumor radiologically?
This is for me.
Yeah.
Yes, we could if we do an MRI with a diffusion study. Especially we will ask it if a patient is presenting with bilateral Wilm tumor and multiple lesion. We will ask for MRI diffusion study, and the radiologists are confident about 90–95% that these are Wilms or nephroblastomatosis.
What are the solid indications, Dr. Shadi as well, the solid indications for core tissue biopsy in Wilm tumor?
The solid indication is the radiologist is not solid about diagnosis. This is the most solid indication. And other indication, if they are older than 6 years of age, between 6 and 16, we should do a core biopsy. Just one word for the core biopsy. It should be done posteriorly and not anteriorly, and by a coaxial needle, not by the normal core needle biopsy.
The question from Dr.
Can I make a comment?
Professor Fox.
Can I make a comment?
Yes, please go ahead, Joy. Yes, 1 minute, Dr. Fox.
I show you an example in my presentation because this in bilateral tumors, if you have after 6 weeks no response in tumor size in bilateral tumors, then in our study protocols, this is also an indication for biopsy because you have to distinguish between anaplasia and predominant stromal tumors. Both show very often no response to chemotherapy. If you have a predominant stromal-rich tumor, then you can go directly to surgery because chemotherapy makes no sense. And if you have an anaplasia, then you can intensify the chemotherapy.
There are more questions for Professor Fox. 2 more questions. Do you use the LigaSure during nephron sparing surgery?
No, I don't use LigaSure. There are two reasons. I have the same problem with extreme resection in liver tumors because you have no so good control with the LigaSure because it's not so easy to say in English. The instrument is not fine enough to distinguish between the border of healthy tissue and tumor. And it's better if you use a scissor because you can see what happened. I show you very well in the video with vascular isolation. And there exist also some publications in liver tumors, not in Wilm tumors, that you have very often an R1 resection. That means microscopic tumor rest when you use a LigaSure in pediatric surgical oncology. Yes.
Last question, if you find it difficult to close the renal remnants, what else the other alternatives?
It is not in each case necessary to close the renal remnants. Yes, I would say in 60%, the kidney is open without closing after reconstruction, and that's not a problem for the child.
Okay, Dr. Fahmy, you'd like to give a comment?
Yes, the last question is mine. I wish to thank Fox for this very nice video, and I'm wondering if you have no chance to close the kidney remnant, you can use other alternatives like putting patch or other tissue to close the renal remnant.
No, it's really not necessary, because when you perform a vascular isolation, then we open at first the renal vein, and then it is easier to close with stitches the venous bleeding, and after then we open the artery. And during this time, you have a significant blood loss. Most of the children need a blood transfusion if you perform stitching of the bleeding vessels and so on. And after then, everything is dry and you need nothing, only fibrin glue and Tachosil, and you have to do nothing. Everything works fine.
Yeah. And for Dr. Shadi and Dr. Ahmed, if there is any plan recently to have a registration for Egyptian cases of Wilm's tumor and neuroblastoma, especially for Dr. Shadi, because in his position in Burj Al Arab and in Alexandria, so at least we may have a registry for Alexandria and some areas in Delta.
Regarding the registry of the Wilm's tumor in Alexandria, we already have it since 2010, a registry for all the Wilm's tumor in the Alexandria and Bahira. What we are embarking on, and actually we are obliged to do, that we work with Arab and 57357, we are part of the umbrella protocol. So we are obliged to report every patient under the umbrella protocol. So both these centers, Burj Al Arab and 5737, are reporting every patient under the umbrella protocol. Other centers are still not reporting. I think SIOP will be joining us soon. And Tanta, I think Dr. Ahmad Abed is doing a great job. We will try to join them to the umbrella protocol.
Yeah, and how much the incidents right now during the last few years?
Actually, we receive in a median of about 50 new cases per year in the northern western Egypt, Alexandria Bahira governorate. About 50 new cases per year in our center. But actually in Egypt, there are much more than this. We have it's an estimate because we do not have data from every center, but about an estimate of we have 400 or 450 new cases of Wilm's tumor per year in the whole Egyptian country.
And it is the same rate, actually, Dr. Fox, in Germany?
In Germany, we have per year 150 cases. Yes, because our population is 86 million. I think in Egypt it's nearly 100 million.
100, yeah.
Yes, and so I think you have some more cases in your country.
Yeah.
Yes.
And as well, 40% of our population is younger than 20 years of age. So we have 40 million.
Okay.
I have a question to Dr. Shadi, please.
Yes.
Yeah, Ahmed, go ahead.
Yeah. Dr. Shadi, I'm asking about what is the percentage cardiotoxicity among your patients after administration of doxorubicin?
Okay, doxorubicin, we do not use it a lot because we are following the SIOP protocol. However, in the past 10 years, since I came back, I've seen only 2 patients that have developed heart failure from the doxorubicin. One was having already a VSD before starting the chemotherapy, and the other was completely normal, but only 2 patients in our series, which are now exceeding the 400 patients, that developed clinical heart failure. We do yearly ejection fraction follow-up for our patients. I could say that 10% of our patients will have a 10% drop in their ejection fraction cardiac outcome. But these are subclinical affection, and we do not do anything except we consider antihypertensive for hypertensive patients, and we ask our children to be physically active as much as possible.
Thank you. Thank you.
I think in a short comment in the literature, we have a restriction of the cardiac function in 15 to 20%, and mainly in the group which receive doxorubicin and irradiation of the thorax due to metastasis. Yes, because this combination is very problematic for the children.
Thank you, Professor.
We have Dr. Hani Gabra among the audience here, and we'd like to hear if you'd like to give his comment or experience on this subject. Hani, can you hear me? You can unmute. Yeah, please unmute yourself and go ahead with the microphone. Give us a short comment of your experience in this subject.
Can you hear me?
Yes, sure.
Yes.
Yes.
Hi, thank you very much for this lovely evening. I really enjoyed, as always, listening to Jörg, and it was interesting to listen to my colleagues from my home country, Egypt. Obviously, we have some experience here, limited experience with nephron sparing, because we get less numbers in my unit than the numbers you often see. And I was teaching on a course with Jörg in February here in Liverpool, and we had a discussion about nephron sparing, and I follow Professor Fuchs' way of dealing with central tumors and nephron sparing, and it's a very interesting technique. And we have done recently a similar case for a child with Kilman's bilateral tumors, and I've shared my experience with Jörg when I saw him about the child actually had quite an extensive tumor on one side, infiltrating the cava, and we did a resection of the tumor and partially and resected part of the caval wall and reconstructed that. The only difference in our experience that we couldn't do both sides at the same time, so we ended up doing one side and went and did the nephron sparing after a few weeks in the other kidney, using a very similar technique. Regarding the MIS surgery for Wilm's tumor in the UK is still in early days. However, recently people started to do more of these tumors, but as Professor Fuchs mentioned, needs to have some significant urological experience or combined urological and oncological experience to do this. And we have quite strict protocols to do these cases, in not just in UK and Europe as well. So compared to Professor Fuchs' experience in minimally invasive surgery for Wilm's tumors, it is quite limited in the UK. One of the other reasons this is happening as well, and we tend to get much bigger tumors in the UK, and those rather than the one seen elsewhere. And I think part of this reasons is unlike other countries in Europe, we get slightly later presentation for Wilm's tumor. And there was a nice paper by Kathy Pritchard-Jones a few years ago trying to explain that. And I think one of the reasons the pickup among the general practitioners in the community in countries like Germany are much higher and much better. So they pick up Wilm's tumor in earlier stage. So they are smaller. So I don't know whether Jörg will agree with me about this comment or not, but this is the finding we have currently in the UK. It's very difficult to add any comments or say anything after these wonderful talks, especially from someone like Jörg talking about his experience in Wilm's tumor. So I think for me, I would enjoy simply to be quiet and listen. So thank you very much.
Thanks.
Thank you very much, Dr. Hani.
Thank you.
I think we have a couple of more questions. Dr. Mohammed Abdulaziz, can you take care of them?
Okay. For Dr. Fox, first question, how do you manage urine leak with NSS?
Urine leakage, yes?
Yes.
Okay. First, I was saying, nice to hear your voice, Hania. Thank you.
Okay, thank you.
Yes, the urine leakage is managed on different ways. If you have a small leakage, you can put a mono-J in the area. That means we perform a retrograde pyrography and put a mono-J directly on the area of the leakage. And most of these leakage closed within 1 week. Yes. The disadvantage is the child needs a catheter because you have to fix the transurethral catheter and the mono-J together. Otherwise, this is very painful for the child. Yes.
Thank you. Next question is, how do you manage patient with positive margin after NSS?
I had now a patient with a positive margin because we perform intraoperative frozen analysis, and if you are unable to perform a marginal R0 resection, you have to decide to go to the nephrectomy. Yes.
Okay. Okay. Thank you. Dr. Sameh?
All right. I think this brings us to the end of a very interesting online meeting. I'd like to thank all the expert speakers.
May I have a few words in the last, please?
Yeah, sure. Go ahead.
Of course, I want to congratulate all of you and thanks for on behalf of the EPSA board being with us. And because this is the last webinar in the month and we'll have 1 month break. But I am reminding you all that we have coming Wednesday, 5th of August, the obituary session for late Professor Hisham Al-Sakit at the same time. Okay, online, to be with us.
Okay.
Please, Dr. Sameh, go ahead.
Thank you so much. So it has been a very interesting night on a high-level discussion on a important subject of updates in Wilm's tumor. We had experts with us in this session, and we received a lot of interesting questions and comments from the chat area. So I'd like to thank you all. You made another successful meeting online. And I wish you that will remain tuned with us for the next and upcoming meetings of Egyptian Pediatric Surgery Association. Thank you all. And I would like to thank all the audience I see from different regions around the world. I would like to welcome them all and thank them for staying with us and enjoying this evening. Thank you all and see you next time.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.
Thank you all. Thank you. Very nice.
Happy feast.
Thank you. Bye.
Thank you so much.
For all.
كل سنة